welcome you all to this wonderful webinar on ADA updates. Before we begin the program, I just would like to wish everyone happy Doctor's Day. We know that since past 1.5 years, what we have gone through, and all the clinicians and doctors have played a crucial role in getting out of all this pandemic. They have served the community selflessly. They have dedicated their time, energy for all of us. So I would like to wish everyone, all the clinicians who are attending this program, happy Doctor's Day. Coming to today's program, today we have a special webinar on ADA updates. Now, we just have witnessed a conclusion of one of the most important scientific events for diabetes, ADA 2021. There were more than 11,500 participants all over the world joined this program online for 5 days. And the research that been presented in this program would help solve more than 460 million diabetic people. So today's program is very crucial for all the clinicians who are managing diabetes. To take us through this program, we have two wonderful clinicians and experts from the fraternity. We have with us today Professor Sujoy Ghosh, sir. Professor Sujoy is the editor-in-chief of Oxford Handbook Series, Southeast Asia edition. He's also international advisor for the Division Textbook of Internal Medicine, that is very well-known medicine book. He's also holding many administrative positions like National Secretary of Endocrine Society of India, National Joint Secretary, Indian Thyroid Research, National Joint Secretary, Research Society for Study of Diabetes in India. He has also worked as a clinical faculty at the University of Glasgow, and he has several awards and accolades on his name. He's recently been awarded American Association of Clinical Endocrinologists International Clinicians of the Year, and also the WIDF Award for the Innovations in Diabetes. He had over more than 300 articles published in various national and international journals, contributed to more than 38 chapters in books, and co-authored 8 books. He's a multifaceted personality, expert endocrinologist from the city of Joy, Kolkata. So I would like to invite Dr. Professor Sujoy Ghosh to the virtual podium to begin the program. Over to you, sir.
Thank you, Dr. Dhiren. Good evening, friends and colleagues all over India, and good afternoon, Professor Davies. And I think COVID has taught us a lot of things, and we've all tried to look at the negative bits of COVID, but the positive bits were, we were all able to actually attend ADA from where we are without having to travel all the way to the United States. And the other good thing that's happened is the world has become smaller. So a program that lasted for about 5 days and which finished less than 48 hours ago, here we have fresh from the oven the updates about what's happened in those last 5 days and what is probably a gist of what the clinician needs to know. And we have a person no lesser than Professor Melanie Davies from the University of Leicester. I'm sure a lot of you know her, and there's a lot of stuff written there on her CV. But some of the things that I like actually is, number one, the textbook of diabetes has a chapter of her on nephropathy, if I'm not wrong. And she has been principal investigator of several trials, professor at University Hospital of Leicester. She has been part of the ADA EASD consensus report on type 2 diabetes management, and also the draft document on type 1 diabetes. She's also a part of that, along with Professor Richard Holt. She's got more than 600 original articles in national and international peer-reviewed journals, and she was awarded the prestigious CBE in 2016 New Year's Honors List and awarded fellowship of the Academy of Medical Sciences. Ma'am, the podium is all yours.
So thank you very much, Professor Ghosh, and it's really great to join you for this discussion this afternoon. It's quite a tough job to try and fit in 30 minutes from a 5-day conference, and I will admit that I wasn't able to get to all of the sessions, but I've picked out some of the sessions that either I have been involved in or I think are of particular interest. So we'll go through this, but as I say, it's really a snapshot of some of the areas of interest. So hopefully you can see my slides there.
Yes, we can.
Excellent. So I'll try and advance them. Oh, it doesn't seem to be letting me advance the slides. Oh yeah, okay. So these are my disclosures. I've worked with a number of the companies when they develop new therapies for diabetes. So what I was going to go through, we may pick up other things in the discussion, was the STEP program, the semaglutide program for obesity care, which I have been involved in and which we published on, and I'll go through some of the highlights from the symposium for that I was involved in. The efficacy and safety of tirzepatide, which is the first GLP-1 GIP agonist, co-agonist. And again, I've been involved in some of those studies. AMPLITUDE-O, so we've been used to having lots of new cardiovascular outcome trials. This time there weren't so many, but AMPLITUDE-O is the newest one that's been disclosed, and I'll talk a little bit about that. The combination of insulin and SGLT2, just a brief mention of that. COVID, I'll go through some of that, but also some of the work that we've been involved with around long COVID as well, as that's, I think, very relevant. And also GRADE was also discussed. So the first one is the STEP program, and this was presented in a symposia. You'll be aware that 4 major publications have come out in the last couple of months, 2 in JAMA, 1 in the Lancet, and 1 in the New England Journal of Medicine. So this is the weight management program for semaglutide at the higher dose of 2.4 milligrams once weekly. Step 1 is the program that was published in the New England Journal of Medicine. Step 3 is a similar design. These are both in people without diabetes, but in step 3, there was also an intensive behavioral therapy in both the placebo and in the intervention arm. Step 4 looks at sustained weight management. So there's a run-in with semaglutide, and then patients after 20 weeks are either randomized to continue on the drug or switch to placebo. And step 2 is the program, the trial that I was the principal investigator. Okay, I'm getting a little bit of feedback, so I don't know if somebody could mute. So step 2, I'll just go into a little bit more detail because this was presented during the ADA. It was a 3-arm study with placebo, and it's interesting because it has the 2 doses of semaglutide, the milligram dose and the 2.4 milligram dose, including people with type 2 diabetes on either 3 oral medications, but not on insulin. The baseline characteristics, we should note that compared to the other STEP programs, these patients were about 10 years older. So in the other programs, the mean age is about mid-40s. In the diabetes studies, it's mid-50s. And there's a more equal distribution of men and women. In the other studies, the other trials, it's a predominance of women. In here, it's about 50-50 men and women. There was a reasonable representation of different ethnic groups and races in this study, and the mean BMI was around 35. This is the main co-primary endpoint, or the one of the co-primary endpoints, the body weight change. And you can see that you see both what we call the in-trial or treatment policy estimand, which is more similar to the intention to treat. And then you have the on treatment, or what we call trial product estimand, which is very similar to the sort of per protocol analysis. And you can see that compared to placebo, both the milligram and the 2.4 milligram resulted in significant weight loss, but there was a greater weight loss with semaglutide 2.4. it was 9.6% mean weight loss with this treatment policy estimand, and a 10.6% weight loss with the trial product estimand. And you can see that while semaglutide 1 milligram also had impressive weight loss, the magnitude of the weight loss was greater with the dose, which is now licensed in the US in the last week or so, or fortnight. FDA has approved 2.4 milligrams for weight management in the US. Now, I don't have time to go through all of the other data, but I'll just show you this graph because I think it's quite helpful. If you look at the dark blue, that is semaglutide. And if you look at the in-trial data, you can see that nearly over 2/3 of patients achieve more than 5% weight loss. 45% achieve 10% weight loss on the 2.4. A quarter achieve 15% weight loss, and 13% achieve at least 20% weight loss. So this is pretty impressive data. There were also significant reductions in waist circumference, a significant reduction with both doses in A1C, a slightly greater A1C reduction with the 2.4 milligram dose, reductions in blood pressure, and a safety profile which is pretty consistent with what we know about semaglutide. So, and this just summarizes the whole program, and this was presented in the symposia. Step 1, you can see this is what we call the treatment policy estimand. So the more conservative analysis, you can see a mean 14.9% weight reduction in step 1, 16% reduction in step 3, which is where you combine the drug with an intensive behavioral intervention. And if you look at step 4 from the beginning to right at the end, the patients that continued on semaglutide all the way through had a 17.4 mean weight loss. And you can see if you look at the what we call the trial product estimand, so the more per protocol analysis, you can see even greater mean reduction. So pretty impressive data. Another poster, sorry, I think it was an oral presentation actually that was also presented, is the Sustain Forte program, which is examining for diabetes the 2 milligram dose compared to a milligram dose. And you can see that you get an additional about 0.3% reduction in HbA1c and just under a kilogram additional weight loss. So this is for diabetes now, not for weight management. So we're going to have semaglutide licensed for weight management for the 2.4. And on the basis of this data, we'll have approval. I'm sure it's been submitted to EME and to the FDA for the 2 milligram dose of semaglutide for diabetes management. This is the key takeaways, really. I think this has ushered in a new era in the medical treatment of obesity, and it bridges what we see between the previous pharmacotherapy and bariatric surgery. And there are ongoing studies, as you know, for cardiovascular outcomes. So tirzepatide, that was the other, I think, breaking data, lots on the tirzepatide program. This first co-agonist looking at GLP-1 receptor agonism now combined with a GIP receptor agonist, which has some additional but possibly complementary effects. So with GIP, you tend to get an increase in glucagon, but you also get these important actions in the white adipose tissue and in the skeletal muscle, particularly around reducing pro-inflammatory markers and reducing ectopic lipid accumulation, particularly in skeletal muscle. So lots of interest in these dual agonists. Tirzepatide is the first one to make it to phase 3. It's a small peptide, a 39 amino acid. It has a fatty acid side chain, which protracts its action. So it's administered weekly. And this phase 3 builds on the data that came out of the phase 2b, where 3 doses, the 5, 10, and the 15, were compared to dulaglutide. This shows the program, the SURPASS program, which was much of which was disclosed at the ADA, but also the obesity program. And there's also studies ongoing in preserved ejection fraction heart failure and fatty liver disease. There was lots of discussion and presentation around the first 4 of the SURPASS program, SURPASS 1, which is versus placebo, SURPASS 2, which was simultaneously published in the New England Journal of Medicine, of which I was involved, and then SURPASS 3 and 4, which were either add-on to insulin or compared to insulin. The program is similar in design for these phase 3. So there's an injectable placebo or active comparator, and then 3 arms, the 5, 10, and 15 milligrams. What we learned from the phase 2 was the need to slowly titrate up the agent to mitigate the GI side effects, and that was the titration that was used. And as I've said, we published SURPASS 2 in the New England Journal of Medicine just a few days ago. So this is the design of SURPASS 2. I think it's a really one of the most interesting of the SURPASS program, because it compares 3 doses of tirzepatide with what I would argue is one of the most effective glucose lowering and diabetes management drugs, which is semaglutide at 1 milligram, which we know certainly within the GLP-1 class has amongst the best A1C lowering and weight data. These are the baseline characteristics: a mean age of mid-50s, an A1C of 8.3. And this is the data, and I think it's really impressive data. So if you look at the mean A1C of 8.3, and if you look at the gray dotted line, which is the semaglutide, you can see that you go from 8.3 to 6.4. Now, we'd be pretty happy with that, but you can see that with tirzepatide, even the 5 milligram dose, you go even lower. And with the 10 and the 15 milligram doses, we're getting nearly 2.5% reductions in A1C down to mean A1Cs of 5.8 and 5.9. If you look at the percentage of participants who are able to achieve what we thought was a good goal of 7%, it's the vast majority in all 4 arms. Actually, 80% achieved it with semaglutide, 92% with the highest dose of tirzepatide. If we go down to less than 6.5, then 2/3 with semaglutide, 87% with the highest dose of tirzepatide. And I think what's really interesting now, and it's opened up a whole new discussion, is that with tirzepatide, more than half of the patients at the highest dose were actually able to achieve pretty much what we would consider normoglycemia, so a mean A1C of less than 5.7. If we look at the weight, it's even more impressive. So we get 6.2 kilogram, a mean 6.7% weight loss with semaglutide at the 1 milligram dose, which is pretty impressive. But you can see that there are dose-dependent greater reductions in weight loss with this agent that's being used for diabetes and glucose management, such that at the highest dose, the mean weight loss was 13.1%. And if you look at the percentages of patients able to achieve weight loss, this is in the realms of a weight loss agent. So 86% getting 5% weight loss at the highest dose, 65% getting 10% weight loss, and 40% at the highest dose getting 15% weight loss. This shows the adverse events. So there were pretty similar total adverse events. There was not such a difference in terms of discontinuation, slightly higher in the tirzepatide arms. But if we look at nausea and vomiting, not so different to what we see with semaglutide. Some dose-dependent increase, but certainly not too much of a concern. So moving now to AMPLITUDE-O. So this was the latest cardiovascular outcome trial with, and I can never pronounce the name of this drug, FMedSci. I have to say it slowly. This was in 4,000 high-risk patients. They were followed for a mean of 1.9 years. They have data from 344 sites, 28 countries, mean duration of 15 years, and 90% had prior cardiovascular disease, and they were randomly assigned to either the FPGME&R or placebo. This is the top line data. So if we look at MACE, there was a 27% significant reduction in MACE compared to placebo with both doses of the GLP-1. If we look at the renal composite outcome, there was a 32% significant reduction with FPGME&R compared to placebo. And if we look at MACE or death from non-cardiovascular causes, there was a 27% reduction in that composite endpoint, which I think is really important. In this study, there was also a not insignificant use of SGLT2 inhibitor, and the benefit, as you can see at the bottom, was pretty similar in those people either on or off an SGLT2. So the benefit in terms of MACE for GLP-1 appears to be independent of the use of SGLT2. So the message, I suppose, is that we need both, and that certainly the GLP-1s, I think, continue to have quite a good, strong evidence base in terms of MACE reduction. Now, what about insulin and SGLT2 inhibitors? Just a couple of brief comments on this. I think we all know in our practice the theoretical reasons of why we might want to combine an SGLT2 inhibitor with insulin. This was presented during the conference, and it shows in the green the combination of an SGLT2 with insulin, and in the pink the combination of a GLP-1 with insulin. Now, I would probably argue that the GLP-1s are probably the older and the daily GLP-1s compared to perhaps dulaglutide and semaglutide. But even so, you can see that in terms of A1C lowering, the SGLT2 insulin combination is good, as good as the combination with the GLP-1. The body weight was also an advantage, and there wasn't so much difference between the SGLT2s and the GLP-1s, although, as I said, the choice of GLP-1s, you could argue, if you'd looked at some of the later agents, that may be a slightly different result. You get a reduction in the dose of insulin and no increase, apart from in the study with canagliflozin, where there was a trend for an increase in hypo. This combination is good in terms of not increasing hypoglycemia. Just a quick mention, there were lots of sessions talking about SGLT2 inhibitors. Clearly, we're in a very good position with the outcome data from outcome studies with SGLT2s. We continue to hear more about the sub-studies from EMPA-REG, CANVAS, DECLARE and VERTIS, which are the pivotal studies. As you know, we've got studies now in heart failure. We've had SOLOIST, DAPA-HF, EMPEROR-Reduced, all of which were positive. EMPEROR-Preserved is due to be presented any day, my understanding is. So we'll get that data soon. And we've also clearly got data from the renal outcome studies as well. And this has resulted in certain regions of the world in label changes. A discussion about COVID. So there was a session around COVID. Clearly, you know, it's been an absolutely devastating time across the world, and you know, clearly it's been very harrowing in the UK, and I know how terrible it's been in India as well. This has impacted on all of us. It's particularly impacted on our patients with diabetes. So we know that if we look across the different studies in different regions of the world, there are a significant proportion of patients who are impacted who have diabetes. There's clearly an association between both types of diabetes, both type 1 and type 2, between poorer glycemic control, the associated comorbidities with COVID-19 outcomes, and you'll be aware of a number of different hypotheses that have looked at this association. There's discussion around the impact of hyperglycemia at admission, this issue about whether there is true new onset diabetes as well. This study was reviewed looking at the difference between poorly controlled and well-controlled patients with diabetes, showing higher blood glucose levels in those with poor control, lower lymphocytes, higher neutrophils, and elevated levels of CRP, and that these are associated with poorer outcomes in those patients who have poorer glycemic control on admission. So hyperglycemia at hospital admission is known to be associated with greater inflammatory response, worse lung disease, and increased mortality. That in hospital poor control and increased glucose variability appears to be associated with poorer prognosis. And I think we're still all trying to understand the exact mechanisms for that, and there's ongoing research. I just wanted to put in a couple of slides because certainly in our country, and I'm sure across the world, the whole issue of long COVID is being discussed. So the definition now, and there's a definition from NICE in the UK around long COVID, so ongoing symptomatic post-COVID syndrome, which are signs and symptoms that develop following or during an infection with COVID that continue for more than 3 months and are not explained by an alternative diagnosis. It's usually multi-system, it's fluctuating, and it can often overlap with clustering and symptoms and follows a relapsing and remitting pattern. Again, there's discussions about the pathophysiological mechanisms of long COVID, which relate not just to the acute infection, but also the inflammatory phase and recovery. And this is some work that Kamlesh Kunti's been doing in our group, but this is a complicated clinical picture. It appears to be a combination of end organ damage, other phenomena, plus exacerbation of pre-existing comorbidities, and it's particularly impacted on by people living with obesity and diabetes, and has many manifestations. There was a really nice systematic review and meta-analysis, which is still in preprint, which did a review of more than 18,000 publications and performed 21 meta-analyses in this cohort of more than 47,000 patients, and showed that around 80% of them continue to have one or more long-term symptoms. The most common symptoms are fatigue, headache, attention disorder, hair loss, and this, I think, is a really nice graphic from the paper that shows you the myriad of symptoms that occur in the different systems, whether it's fatigue, headache, depression, mental health problems, to respiratory symptoms, to joint pain, associated often with ongoing biomarker abnormalities like D-dimer, pro-BNP, CRP, ferritin, and procalcitonin, and also a significant proportion of patients having abnormal X-ray. Now this description of these post-COVID syndromes, whether it be neuropsychiatric, cardiorespiratory, thromboembolic, dermatological. So clearly, not only do we see the manifestations of the acute illness, but we're now starting to deal with the post-COVID syndromes. So finally, just a few brief comments on GRADE. So GRADE has been this eagerly awaited study that was funded by NIHR. It's a head-to-head comparison of what at the time were the 4 commonly used classes of medication after metformin. So this was insulin, a GLP-1, a DPP-4, and a sulfonylurea. The GRADE trial was looking at their ability to keep average blood glucose in the recommended target as indicated by an A1C of less than 7. Compared, as I said, to oral medications, an SU, glimepiride, and a DPP-4 inhibitor, sitagliptin, with 2 injectable medications, glargine and liraglutide. It's 5,000 patients, so it's roughly about 1,250 in each group. These were meant to be patients with a relatively short duration of diabetes, and they were randomly assigned to each of these 4 medications and was conducted to have an average of 5 to 7 years follow-up. Now, I couldn't find all of the information on this because not all of it has been published. I suppose the comments I would make is that this was a population who had relatively low cardiovascular risk. It was patients clearly with a relatively short duration of diabetes. As I've said, they were looking predominantly at the glycemic control, and the preliminary data that was presented showed that liraglutide and insulin appeared to be better at both reaching and keeping A1C at target. The preliminary data, but there was a lot of caveats about this, and I haven't seen the full data published, showed benefits of lower events from liraglutide. Clearly, there are lots of shortcomings in this. There was no SGLT2 arm. The microvascular outcomes were presented and really showed not particular differences, particularly in the renal outcomes between glargine, the SU, liraglutide or sitagliptin, both in terms of moderately or severely increased albuminuria, or indeed if you look at EGFR or neuropathy. So from a microvascular point of view, there didn't appear to be any particular signals in these patients, but still I think quite a lot to come out of GRADE. So certainly the data that was presented showed there was no particular differences from a microvascular complication impact of these 4 groups. So I'll leave it there. So just those are the topics that I've covered. Clearly, I haven't been able to cover them in great detail, and I'm sure there were many other things that were presented that I didn't get to or that we haven't had time to cover in this short session. So thank you very much, and back to you, Professor Ghosh.
Thank you very much, Professor Melanie Davies, for that excellent lecture. I think it's very, very difficult, like you pointed out, to try and summarize what's happened in 5 days in 30 minutes, but I think you did an excellent job. And if I could start by, going to each of those bits of the studies that you talked about, because we still don't have, and I don't seem to have any major questions in the chat box, starting from the last one, that is GRADE study. I think it reminds us of UKPDS, something that MRC funded in the UK. This is something that's funded in the US by NIH. For the first time, at least, we have a study looking at drugs independent of funding from pharma. And like you said, it would have been wonderful had SGLT2s been on board. And I think most of Europe uses glycoside in terms of sulfonylureas, whereas glimepiride was used in this. And like you stated, it's still early days, preliminary data. The CV events have not been adjudicated, and probably the study is not even powered to look at cardiovascular outcomes. But, from your clinical experience, would you seem to, sitagliptin had a far shorter glycemic durability compared to glimepiride. Is that something that you would have anticipated to see?
So I think, since GRADE was, and that's the problem, isn't it, with all these studies? Oh, fine. Yeah, that's the problem with a lot of these studies, is that at the time you design them, they seem to be very relevant, but 5 or 7 years down the line, the world slightly moved on. And I think, I think there is a bit of a move away from DPP-4 inhibitors. DPP-4 inhibitors were used a lot, I think, early on, because there's no doubt that they're very easy to use. So patients like them. There's a low risk of hypos. You don't put weight on. And I think from a usability point of view, certainly in the UK, primary care like them a lot because you can prescribe them and they're easy to explain to patients. I think on the downside, we've not really seen the data come through from the outcome trials that they do any more than safely lower glucose. And I think now the bar is higher in that we want cardiorenal protection for patients. We want durability. I do think the SGLT2s are really, it's a real shame they just missed in the US, certainly in Europe. And Asia, I think the SGLT2s were already licensed and available at that time. But if you'll remember, there was a bit of a delay for dapagliflozin getting available in the US. And so they had Cana first, and it was a year or so later. So we missed getting the SGLT2s in that study. But I think now, my perception is I'm not so surprised that sitagliptin didn't come out. I wouldn't have expected it to come out better than insulin or liraglutide, to be honest. I think we've got. I think the SUs come out actually reasonably well, but we also know that from the Carolina study as well, where really the main difference is the weight and hypos, but over the longer term, in terms of micro and macrovascular complications, there's not such a big difference between the DPP4s and the sulfonylureas. But I think the question is whether the SGLT2s and the GLP-1s, and particularly some of the later GLP-1s like dulaglutide, semaglutide, where you can give them weekly, you're getting really convincing data from the outcome studies. And of course, now GLP-1s are available orally. So I think that's sort of a bit of a gap, but it has helped us about the positioning of DPP4s, I think.
Right. I think, whenever we've spoken about sulfonylureas in the past, we've blamed the sulfonylureas for beta cell exhaustion. We've blamed them for hypoglycemia. We've blamed them for weight gain, and we've blamed them for bad cardiovascular outcomes. I think with whatever preliminary data is there in the grade, it would actually suggest that it's not that bad. I think, to me, as a person working in a developing world where cost of drug is a big issue, I think it actually makes a big point in terms of the sulfonylurea. And in India, glimepiride is prescribed much, much more than glycoside, because I still remember working in Glasgow where you used to prescribe glycoside, but in India, glimepiride sells much come out of grade, and I'm sure there'll be at least 10, 20 papers coming out of grade at some point of time in the near future.
I do think it does provide some reassurance for sulfonylureas, particularly I think compared to the DPP4 inhibitors. And we sort of saw that with Carolina with the cardiovascular outcomes. I think for some patients, DPP4s are excellent when you're really wanting, if you've got somebody with renal impairment that you want to be careful about hypoglycemia. I still think the DPP4s have a role, but I don't think, I think the mass use to replace the sulfonylurea, which is sort of where we were going, is probably not warranted, really.
Right. So coming next to the AMPLITUDE study, here we have a GLP-1 receptor CV outcome trial, if I would put it that way, where an exendin-4 based drug has actually shown positive results. In the past, none of the exendin-4 based GLP-1 therapies worked. So is there any reason why that might have happened? That is one question that I would like to put forward. The second is, this is one trial where you have renal outcomes as well, unlike the other GLP-1 studies where we were not very sure about the renal outcomes. It was heterogeneous in terms of the data that was there, and in half of the time it wasn't powered enough to make any comments. The last bit is, in every CV outcome trial, we keep on saying that you've got to reach glycemic equipoise. And in this trial at the end, there was a difference of 1.24 HbA1c between the two groups. Now, could that have influenced the microvascular outcome data of the renal data? Or do you think it's just because of the drug itself?
So they're all fantastic questions. So the first one is, I suppose the jury was always a little bit out of whether this was the extending effect or whether it was the study design. Excel just missed its endpoint, and and people have argued that that was partly about the conduct of the study and how many people were still on active treatment rather than it being the actual agent. Lixisenatide, I think, is more difficult because the population was completely different. It was an acute coronary syndrome population. And I do think lixisenatide is a much more mild agent, both in terms of its impact on anti-inflammatory effect, its impact on weight, and its impact on glycemic control. So, I think that there was one hypothesis, was this all about extending GLP-1s? Or I think it's always been debated as to whether it's the drug, the conduct of the study, or the population you study. I think for me, it just gives us a bit more confidence about GLP-1s having, I think, quite a consistent and robust story about MACE endpoints and atherosclerotic cardiovascular disease. And I think that is reassuring. I think if you look at the meta-analysis, and there was a good meta-analysis published across the GLP-1s, actually the renal endpoints are a little bit more consistent. So Rewind, I think, was pretty consistent, and the data was fairly robust. I think we've got, I think, a good story around GLP-1s reducing albuminuria and contributing to good and improved renal endpoints. But the story for the SGLT2s is much, much, much more powerful. And so I think for me, the SGLT2s win. But if you need a second agent, or if you can't use an SGLT2, the data for GLP-1s on renal endpoints, I think, is more positive. And this helps that narrative, I think.
Right.
And sorry, I can't remember your third point.
I was asking about the glycemic equipoise. Could that have actually?
Yeah, and I do think with all of these, there's been mediation analysis with SGLT2s and with GLP-1s suggesting that at least some of the effect is independent of glucose lowering. But at the end of the day, it's quite difficult to pick that out when you have therapies. For example, particularly I think with tirzepatide coming through in their outcome study, and with semaglutide, where you have very, very powerful glucose lowering and weight lowering agents. At the end, it's likely to be some intrinsic effect, a pleiotropic effect. It's likely to be an indirect effect, I think, on weight and blood pressure and glucose. So I think it's probably likely to be just, as we in practice, it's a multifactorial intervention, and some of these drugs give, target more than one thing.
Right. Moving on to the next bit, that's the STEP studies. Now, conventionally in any international congress that you go to, you would have debates on whether you go for medical management of obesity or whether you go for metabolic surgery. And when you look at the kind of weight loss that people can possibly achieve with metabolic surgery, medical therapy has always taken a backseat. But now, after the publication of the STEP, and more importantly, after the SURPASS-1 and the SURPASS-2, do you think we are reaching a stage where medical therapy can give metabolic surgery a run for money?
I think we are, really. I think, I think there will still be, and in some ways there may be even more metabolic surgery now because more people perhaps may come forward for management. I do think we've started to bridge the gap. I think there was a big gap. I was involved with liraglutide, the 3 milligram data in diabetes, and that, was reasonable, but you're getting sort of 5, 6, 7% mean weight loss. Now, certainly we're getting double-digit weight loss, even in people with diabetes. If you look at the per protocol analysis, it was more than 10%. And if you look in people without diabetes, you're getting 15, 16, 17% mean weight loss. So I think that is starting to bridge the gap, and I think it gives us the opportunity of using these agents before metabolic surgery. It also opens them up for being used in the longer term, perhaps for weight maintenance in people that regain weight after metabolic surgery. And it gives an option for people that either don't want to choose to have metabolic surgery or in whom that's a problem. So I think it just adds to the options now, and that's got to be good for patients. What we just need to do is to make sure that these therapies are affordable and accessible to the people that may need to use them. The other interaction, of course, is with data now from DIRECT and from some of the opportunities that we have with some of the low energy diets, the opportunity to combine intensive lifestyle with pharmacotherapy, I think, is also increasingly an option.
Well, if you look at SURPASS studies, do you not think the results are too good to be true? You're having A1C reductions of over 2%, something that we've not had with medical therapy in the past. That's number one. Number two, you look at the targets that you've reached. Some of them are 5.8s, 5.9s. So, we've come a full circle from 2007 when you had ADVANCE and ACCORD published. Everyone trying to tell us, you probably shouldn't lower HbA1c below a certain point because it wasn't perhaps safe, and you probably increased cardiovascular problems by doing so, to now a situation where we might have therapies to lower blood glucose levels and to A1Cs to even levels less than 6 safely with improved outcomes. So do you see a possibility in the near future that the targets of A1C might again change? That now the fact that if you are going to have agents which can safely lower glucose values even more stringently, and of course, this group of drugs, the twin cretins as they are called, or maybe the third one, which you have the glucagon receptor blocking agent along with it, that probably these group of drugs are going to dramatically change the way we manage obesity and diabetes, just as probably how SGLT2 has changed probably the management of diabetes dramatically. And the next bit is, we were all talking about and getting excited about oral semaglutide coming in and being a game changer. Now, if you look at semaglutide, it looks, like a dwarf now next to the twin cretins. You're comparing that and seeing that this is superior in terms of the glucose lowering as well as the weight. Sorry, too many questions.
Yeah, no, that's good. So, the too good to be true question, I do think, when these studies were designed, when you looked at the phase 2 and you look at the tolerability, there was some discussion around the titration. I think they've got that right for the phase 3, but I don't think we it wasn't possible to predict how low the A1C would go. And, when you look at that data and you see in diabetes patients, more than half of them getting to a mean of 5.7, it is pretty amazing, really. So, but I think the data is great. I think the tolerability looks good. I do think it opens a whole discussion now about what the aim of treatment would be, because now it may be possible for patients to go into remission of diabetes. We might need to think how we define remission, because at the moment you have to be a remission off treatment. And I don't think, most of our experiences with these agents is when you stop them, things tend to return. I think in terms of your future treatments, I do think that we are, this idea of a peptide backbone that you design in, and you have either hybrids or chimeras where you have coagonists or triagonists for obesity and diabetes is the way we need to go. The glucagon receptor antagonists have been, or agonists, they've been both looked at. In animal studies, the triagonists look amazing, but we're still a little bit way of that in clinical, in human patients. But the dual agonists, the tirzepatide's coming through. There was another one coming through with amylin, which looks very good. So I think we're going to be spoilt for choice. I still think semaglutide looks, the STEP data is amazing, and it's now licensed for weight. There's a program looking at higher dose of oral semaglutide. I think as we use these agents and we get used to different doses, and also the the 2 milligram looks pretty good as well. So I still think, semaglutide has a major role to play moving forward. And there's also another oral GLP-1 in development. Some of the data was being presented at an early stage. So I think there will be a number of these agents coming through, but we will need to rethink what is possible safely, because the discussion around intensive management and low being bad for you is based on old agents. It's also based on different patients. The patients we see now are more obese, they're younger, they have worse beta cell function, they progress more quickly. So we need better treatments for those patients as well.
Right. One of the doctors, Dr. Vikas Bhattacharya, has highlighted that, we've not talked about GIP in the past. Now all of a sudden we are now talking about GIP. And for the benefit of the audience, if you could tell us actually how the GIP helps the GLP-1 pathway to act better with these twin incretin drugs.
Yeah, so Dan Drucker has spoken about this. I think the jury's still out of whether this is completely the GIP bit or whether this is just a magnificent GLP-1 receptor agonist. So it's clearly Lilly colleagues have argued very much it's a co-agonist. I think there's still some debate around what proportion of the action is GIP and what proportion is GLP-1. Clearly, there are similar actions in terms of reducing some of the central effects. And we know that, for example, tirzepatide probably is getting in centrally, but clearly it reduces food intake and body weight. And there was some suggestion that it may mitigate the nausea. So one of the discussions is that if you put GIP into a co-agonist, that you can get to higher doses with better GI tolerability. But I've heard that discussed, but I'm not sure we completely understand all of that. Clearly at the pancreas, it increases insulin, but it increases glucagon, whereas GLP-1 receptor agonism reduces glucagon. And I think the role of glucagon, both in terms of weight management, but also in glucose control, is still not completely understood. But I think it's the impact in the white adipose tissue, so improving insulin sensitivity. It increases the storage capacity, increases lipid buffering. Has an impact in reducing hyperglycemia from dietary triglyceride, but also this impact in the skeletal muscle, which GLP-1 doesn't tend to have. So I think we're still at the very early stages of completely understanding the role of GIP and how much it's playing in this particular agent, but it's certainly quite an exciting area.
The other thing that we, at least in India, face when we talk about the GLP-based therapy, there are essentials. Number one, the cost. So if you think of those three problems, that is, it's injectable, it's expensive, and tolerance, particularly the newer drugs, the twin incretins, and even the higher doses of the GLP-1s that we are now talking about in the use of obesity. In your experience, how do they compare in terms of tolerance compared to the conventional older GLP-1 agents that we've been using? Because in India, for example, hardly do we find someone who's on liraglutide 1.8. 0.6, yes, 1.2, yes, but very few tolerating 1.8.
So, I think there's a couple of things, isn't there? At the moment, it's still amazing to me that after it must be 12, 15 years since exenatide, that in most parts of the world, if you look at the usage of GLP-1s, even in these trials, if you look at some of the outcome studies and with SGLT2s, what proportion were on GLP-1s, it's always less than 10%, so even in, the States and in countries where, these drugs are a little bit more accessible, it's still off. It's only the minority of patients in whom they're prescribed. Okay, so either, you know, so we're still, I think, at a stage where we use GLP-1s quite not so much. I use them a reasonable amount in our clinic and in our hospital, in the NHS. They're reimbursed, so we can use them a little bit more. And I think as you use them more, you get more experience with their use, you get more experience at educating patients, you get, I think you almost normalize their use a bit more, so we get used to doing that. And I think that if you use the titration is absolutely key, and the education of patients. And I think that often actually the tolerability is not such an issue. I think it's more the access, the cost, and the experience of healthcare providers being really comfortable with their use. Also, I think with the injectable now, dulaglutide particularly is really easy to use. Semaglutide, the weekly injections, many patients actually prefer a weekly injection to a daily tablet. I think now we've got oral sema. There are other, as I said, there's other agents in the pipeline as well, oral GLP-1. So, but we really need to address the access and cost and availability of these agents, I think.
Right. There are a few other generic questions. There's one from Dr. who's asking about whether the SGLT2 inhibitor effect in terms of the renal outcome is more of a class effect rather than individual effect. And Dr. Degmando has asked about, in the GRADE study, with whatever little data that we have as of now, the GLP-1 does not seem to have any renal benefits.
Yeah, so in terms of the SGLT2 inhibitors, I think probably they're more similar than different, but there are some differences. You know, we've seen some differences in the safety profile. We've seen a little bit of differences around the SGLT1 activity and whether we think that's important. The sotagliflozin data would suggest it's possibly not terribly important. There was some suggestion that both the renal indication in terms of how low you could go with the eGFR and get glycemic benefit may be an advantage with the agents that have SGLT1 activity. That doesn't seem to have come through actually from the studies. And as you know, sotagliflozin is not really being pursued now, mainly because of that. But I think if you look at the Darren Maguire's meta-analysis after Vertis, you could, if you use the same renal composite and you look across the studies, they're really pretty similar. And the I-squared for heterogeneity was 0, suggesting there wasn't a lot of difference. So I think that's probably right. But, you know, at the end of the day, you should use the agent where the license exists and where they've, you know, done the trial to prove the primary outcome is what I would, you know, what we don't want, you know, we want companies to do high quality studies to give us the licensed indications. And GRADE, I mean, yeah, as I say, I've not seen, you know, there was the presentations, I've not seen so much of the data published yet. I showed you some of the renal data and there clearly wasn't a huge difference between the 4 agents. But what I would say is, and I think you made the point, Professor Ghosh, that these are low duration, fairly low risk patients, and the study's probably underpowered to look at some of these outcomes.
Right. And retinopathy safety with GLP-1.
Yeah, so I think we saw that signal in SUSTAIN 6. There's ongoing study.
That's again a comment rather than.
Yeah, so I think I think that's reassuring. There are ongoing studies looking at that. We certainly didn't see anything in AMPLITUDE-O.
Right. I think we've had a fantastic 1 hour, 30 minutes of you telling us about what was happening at PAD, and then a very, very lively panel discussion in terms of the questions that you've answered, ma'am. Thank you very much, and hope to connect with you again soon. And I would hand over now to Dr. Dhiren for the next bit of the session. Thank you so much.
Thank you, Dr. Sujoy, and thank you, Dr. Melanie, for the wonderful discussion. I think today we have a very good, we got a very good insight in the management of diabetes and what's in there upcoming for the diabetes patients. And before we conclude, I would just like to have one more question to both of you. We have seen that in past couple of years, the management of diabetes has changed significantly. Particularly after the introduction of SGLT2 inhibitors. Now we see that many of the guidelines are being changed, and talking about like European cardiology guidelines, they have given the SGLT2 inhibitor the #1 rank before the metformin as well. So one question that I would like to ask to both of you is that now with the coming of dual incretin inhibitors, where do you see the guidelines going in terms of management of diabetes ahead? What do you see in coming years?
So I think, I think that it's great to talk about drugs before metformin, but the reality is that most of these studies, patients have metformin on board, and the meta-analysis doesn't show that metformin worsens. In fact, if you look at the AMPLITUDE-O, there was a sort of suggestion that being on metformin was slightly beneficial. Metformin is cheap, it's accessible across the world. There's lots of clinical inertia. We need to get patients on therapies early. We shouldn't delay the addition of SGLT2s because of metformin, but the biggest scandal is that not more patients are on these protective agents earlier. It's still the minority of patients who should be on these agents are on them, and we should focus on that, not on little bits of discussion, which I think are a slight sideshow. The main scandal is that many patients who are at risk of cardiorenal disease with diabetes are not treated early and are not treated with these therapies at all.
Agreed, completely agreed. And the other thing is we are excited about these newer agents, but I think it's still going to be a few years before these agents catch up with where even the SGLT2s are today. SGLT2s didn't become SGLT2s overnight. It took them years to generate evidence, particularly with regards to the cardiovascular outcomes, the renal outcomes, the heart failure data, before they came where they are now. So similar with these group of drugs, the twin incretins and the GLP-1s, I think we need more evidence before we actually come to that stage. But always remember that they're going to be expensive drugs, and most of them are still, as of now, injectable drugs, which might not be the best thing that's acceptable to patients. But over time, as we generate more and more data, I think they will catch up that second-line drug or the third-line drug place, which is not being used right now. Because in spite of the ADA guideline talking about the GLP-1s and the SGLT2s immediately after metformin, how many of them are actually on it?
Yeah, so I do think there's a bit more movement around GLP-1s in Europe and in North America now, but I think both the use of SGLT2s is going up. It's still lower than it should be. Certainly, we have a lot of obese patients or patients with obesity and type 2 diabetes. And so, there is a fair amount of GLP-1s used, particularly, I think, since dulaglutide and semaglutide, where they're weekly. And we don't have such an issue with where they're reimbursed under the NHS. So from a patient perspective, it's not the patient that's paying for that agent. So there is a bit more access. But I agree, but and I also think what we haven't talked about is in some patients, actually the combination of these agents is important because they do different things and they may well complement each other. So, but I think we've got a long way to go to get these really, that's what we should be focusing on, getting these agents used more routinely earlier.
And rightly pointed out by you in the AMPLITUDE study, you had almost about 20% who were on both. So it's not that A and B are exclusive, but they are complementary.
Thank you so much, Dr. Sujoy and Professor Melanie. Indeed, we had a wonderful discussion, and I would like to take this time to thank all the clinicians who are watching this program, sparing a valuable time for this AD updates. I thank you. I also would like to thank both of our experts, Dr. Sujoy Ghosh sir and Professor Melanie Davies ma'am. It's been a pleasure of us having both of you on the stage, on the virtual podium. So on that note, I would like to thank you once again. Everyone, goodbye, good night.